Jeg vil gerne sige godmorgen, goddag. I'm from Denmark. I'm married to a Norwegian guy and I'm working in Sweden, so it's really Scandinavian. I have license to kill as a surgeon in all countries. I'm not going to kill anybody today, I hope. I hope that I'm going to support a better future for all of us. What I'm going to present is about the importance and impact of quality and health and care organizations, all together with the presentation of our international network of health promoting hospitals and health services. It was established as a network for hospitals exclusively. However, back in 2005, we opened it for primary care for everybody else, and now also for affiliated members. So if you're not yet have joined the network, your organization has not yet joined the network, please do so. Our network is very important. When I say our, it's established by WHO. I'm working at a WHO collaborating center both in Copenhagen and another one in Sweden. Becoming a patient is a very critical stage in your life for most people. Illness and treatment are often stressful, both physically as well as mentally. And it's therefore important to improve treatment results and to promote faster recovery, both for the individual patient and for the society at large. And here, HPH is an important part of the solution. I'll show to you why I say this. This is our network today. It's not persons who can become members, it's only organizations. And we have about 660 members from all over the world, at least in all continents, I can say. And we have the real members, the hospitals and the primary care, the core members, but we also have the affiliated members. And there's a network in Norway, of course. Also, maybe you are familiar with some of the members here. At least I know that St. Olav Sykehuset has been a member in many years. Our structure is very simple. The member is in charge. You see the board. It's not a traditional pyramid. You see the board is the side to implement what the members decide us to do. And it is actually a network of networks. It means that all the networks that exist all over the world create the international network. And all networks have a seat in the International Network's General Assembly. The aim, the goal, the overall goal is to get better health gain. Not just better health, but better health gain for patient, staff, and the community. And also we include the environment. We build on strong evidence. And that's really hard because the evidence change from one week to another almost. And we have to follow that. We cannot build upon ideology. A very brilliant lady from Norway, the previous General Secretary of WHO, Gro Harlem Brundtland, said, when you are working with health promotion, you should not build it on ideology, but on evidence. And I completely agree to that. We have simple tools to use. I mean, this is a very comprehensive network, very comprehensive activities, but the tools are so simple. Why are they simple? Why are they easy to use? We should be together with the patient and everybody else and the relatives. We should not spend all the time in introducing this tool, so they have to be very easy to use, very simple, very smart, validated, etc. We actually today have 3 of those very easy to use tools. One includes standards, and maybe you know from accreditation company, Joint Commission, etc. They have about 600 to 800 standards. We have 5 to cover all health promotion related to patient and staff. 5 only. And we have some few models on how to describe what we are doing in the hospitals together with the patient and the staff. You might know all these documentation systems that exist for medical records. They have about several thousands of diagnoses and descriptions of interventions. We have 16 and 10. So it's really, really easy to use these tools. We don't want to have them, we don't want to spend the resources on doing this. However, it is important to do. We are now working very much with implementation. Why do we do that? Because it's needed. It takes up to 17 years to go from having the evidence in one hand and to have it implemented for the patients in the other hand. 17, I mean, I'm a surgeon. I don't have the patient to wait for 17 years to have my patients to get the best evidence. It doesn't work that way. We have to do it much faster. We've been looking into the world literature, and we have identified 62 different models and frameworks published for implementation and dissemination of new knowledge and evidence. Either all of them work, so it doesn't matter what you do, or none of them works. That's why we have so many. Probably the last thing is the correct answer to this. The problem with those are that there are almost no evaluation. We don't know the real effect. Most of them are theory-based, but they have not been evaluated in real life. They are only partly data-driven, or not at all data-driven, but only theory-driven. And they have no engine. They have no activities that promote them forward, and they have no time frame. So that was why we started the international project, together with 8 countries in the world, and developed the fast track implementation model. This is purely data-driven. It's easy to use. We have tested it in a randomized trial. It's very effective. It integrates quality improvement, implementation science, and 1 year of implementation. It has a time frame of 1 year. It's in publication right now, and one of my PhD students is going to defend his PhD thesis in September on this subject. The staff is important. We have to remember that for us, the patient is the main person. The relatives are very relevant, of course, and very important, but it is the patient who is in center. It's a patient that we have to support and empower and do all these good things together with. But the staff is also important, both because the staff are our tools to reach out to the patients, but also because the staff themselves have to be reached out to, if you can say that. We want to have healthy workplaces, and we want to develop competences and build capacity. So we have teaching and training sessions for our staff. How does it work, this health promotion activities aimed at patients? Well, this is something you learned in school when you were a child, or at least later on. Unhealthy lifestyles give lifestyle-related illness and problems. If you change your lifestyle, you will have a reduced lifestyle-related illness and problems. But that's only half of the truth. Have a look here. Unhealthy lifestyle also aggravate treatment outcomes of other diseases. I mean, if you're a smoker, you don't get pregnant due to smoking. But if you're a smoker, you get a lot and pregnant. Then you get a lot of complications, both for the mother giving birth, but also for the child that follows the child several years afterwards. So it's not related, it's not only the illness, the lifestyle-related illnesses that is important here. It's any kind of illness. And in addition, if you quit smoking or quit drinking or quit whatever, then you will get better treatment outcomes. What do I mean by that? Have a look at the surgical results here. Though they seems a little old, there was the very first interventions worldwide showing that if you quit drinking prior to surgery, you could reduce the complication rate tremendously. to about half, but look at the level. I mean, if you play lotto or something like that, then this is almost guaranteed that if you undergo major surgery, drink too much, then you will come out with a complication. The other one, the next one concerns smoking cessation intervention in relation to surgery. The very first worldwide randomized trial of intervention. We have had this knowledge about smoking and postoperative complications since the end of I think it was 1948 or something like that. The first paper was published. More than 50 years after we did the first intervention study. Come on, what is going on? We see a problem, we don't solve it. We have to do that much better. Look into diabetes. The left part here, the very first, there should be a laser somewhere, yeah. The very first part is about death. If we have a comprehensive program here, we can reduce the death rate in relation to cardiovascular diseases, the stroke, the myocardial infarction, but also all the serious complications in addition to those that require surgery is reduced. This is amazing. If I could put that into a tablet, I would definitely get the Nobel Prize, I'm sure. What about mental illness? Shouldn't you be allowed to smoke if you have a mental illness? Well, of course you're allowed. I mean, you can do whatever you like to, but look at the effect of quit smoking on mental illness. This is not only on patients with psychiatric diseases, this is for everybody. So it's a collated results showing the effect on mental health, mental function, if you quit smoking. And you see that after you have passed the withdrawal symptoms, then you get lower level of anxiety, lower level of depression. If you measure both, it's also lowered. You lower your stress level. You increase your quality of life when you report it by yourself, and you get more positive feelings. I mean, come on, who wouldn't like to have that? So of course we should also do something here. Okay, and if the numbers here does not count, this is the last slide. If it doesn't matter what the patients, that they get better, then look into the business cases, look into the money. This is really where you can save a lot of money. If you have a person drinking 2 drinks or more per day, undergoing, for instance, acute ankle fracture surgery, then the cost of this patient is about 13,000 euros per patient. Usually we have a cost of 5,000 euros per patient. So it's really a lot of money. When we talk about health promotion for patients, it's not about spending money. You should start discussing how should we use the money we save. That is much more important, because it's so easy to do, it's so cheap, and it's so effectful. So hopefully in the future we will look like this, that we get more equity in the world. Not everybody should have the same, but those with the highest needs should have most. And then hopefully we can give health promotion activities to those with the highest needs, and then get a much better outcome in any way for all our patients. Not only in Norway, not only in Sweden or Denmark, but all over the world. Thank you so much.